So it's an interesting position to be in. I'm an interventional cardiologist, but my roots are as an internal medicine doctor. So we all go through internal medicine training. And in that, in doing some of the interventional things that I do, side by side with vascular surgeons, it's very interesting because my internal medicine training, I'm finding, was an impediment in some ways and was very helpful in some ways. But for DVT treatment, I think it is an impediment because many of you in this room think about DVT and you think about Lovenox, Coumadin, home. And that's it. And that's why this talk is one slide. And I'm done. But no, that a lot is the internal medicine approach or the ER approach to a DVT. Regardless of anatomy, regardless of how the leg looks, DVT equals anticoagulation and home, or rule out PE and home. But it's just not that simple. And so this is going to be a review of guidelines. The most recent set of guidelines were from 2012 with multiple updates since then. We have novel anticoagulants that we can use. But the most interesting thing is prevention of the long-term sequelae of devastating DVTs that can't be grouped into that Lovenox, Coumadin, home continuum, that have to be differentiated out and really selected for an interventional approach. So just thinking about the anatomy, very important to understand that there is a superficial venous system and a deep venous system. I think DVTs, but what does that mean? The DVTs have more of a straight shot to embolize to the lungs, but the superficial venous system can also then trigger blood clots that can be a risk for a PE as well, especially when there's a substantial amount of thrombus in the larger superficial veins. So the saphenous veins, the greater saphenous, small saphenous, are the superficial system, and then the deep system are the below the knee veins that are not the saphenous veins, the popliteal vein, and then the femoral vein. And then up at the top, I don't know if there's a pointer here. Is that a pointer? The top button. Okay. So up at the top, this is a very important anatomical feature, which is the saphenofemoral junction. And anything that is proximal to that, you can think about this as the one door out of the leg. And if you have a clot that has compromised your saphenofemoral junction, then there is no venous outflow from the leg except through collateral flow. And so then that's a person that now has a brand new risk for the long-term sequelae of venous thrombotic disease. If you have a superficial clot or if you have a deep clot down here, there still is an alternative pathway out of the leg. But this is just very important to think about. So if you have a clot that's proximal to the saphenofemoral junction, what we call iliofemoral DVT, that's something that really does need a vascular consultation to help with the decision making. We have a set of guidelines for management of venous thromboembolic disease. So from 2012, again, there's been 3 updates since then that basically have brought in the novel anticoagulants, given them ratings for the recommendations. But really, the recommendations there's been no significant updates since 2012, and these are these are published in Chest. Diagnosis of DVT. So this is all kind of a review of the guidelines, and I learned a ton that I never even touched on at all in my training. And in vascular surgery, I think that it's probably more comprehensive assessment of this, but you may not have touched on the medical management as much. But to really make a diagnosis of DVT, just like with any test, you need to establish the pretest probability to establish how accurate a diagnostic study is going to be in the diagnosis of a condition. Okay, so you establish your pretest probability. What are the risk factors? Is this a patient who is a smoker on oral contraceptives? Is this a patient with an underlying malignancy? And in low to moderate pretest probability patients, using a D-dimer is a good predictor of whether there's a DVT there or not. A negative D-dimer is a negative predictor. And then rule out DVT if your pretest probability is higher, would be a compressive ultrasound of the proximal veins above rather than doing the whole leg. If you have a high pretest probability, then looking throughout the entire leg with ultrasound. And then moderate to high probability patients with a negative ultrasound, repeating a D-dimer. That's something that we aren't really doing to follow on with patients. But a lot of these recommendations do have a follow-up ultrasound or a follow-up lab study. The initiation of low molecular weight heparin until the INR is therapeutic on Coumadin, or initial use of the novel anticoagulants for treatment of a DVT. However, no anticoagulation in a DVT distal to the knee without severe symptoms or risk factors for extension. I have a patient that had a brain bleed because he was treated for months and months on Coumadin for a below-the-knee DVT, an old man. And this is one of those examples where a follow-up ultrasound is very important to assess for extension above the knee. So a follow-up ultrasound, serial imaging, 2 weeks afterwards. And then, interestingly, this is something that I don't ever see done, but low molecular weight heparin at 2 milligrams per kilogram once per day is an alternative to 1 milligram BID per kilogram. Okay. Early ambulation is okay. Nearly all recommendations are for 3 months in a provoked or unprovoked first DVT, and then cessation of anticoagulation. With recurrent DVT, the recommendation is just simply for more than 3 months. A lot of it's what is the underlying condition? Do they have a hypercoagulable state? Do they have some sort of venous compression syndrome, like massive lymphadenopathy that's decreasing the venous outflow from the leg? In a DVT with cancer, the recommendation is not Coumadin. It's actually ongoing low molecular weight heparin treatment, which I didn't know, and that's, again, not something that's standardly done, but that's the recommendation. And the 2012 guidelines, again, were written prior to the safety data on the novel anticoagulants, but those have now come in really as Coumadin alternatives and are overall safer than Coumadin in real-world use in terms of bleeding, and are probably more efficacious at stroke prevention with AFib, too. And then the recommendation for all DVT patients is compression stockings for 2 years if they have any post-DVT symptoms. So other recommendations from the ACCP guidelines: superficial thrombosis that's greater than 5 centimeters, using fondaparinux over low molecular weight heparin. Interestingly, an injected medication. In upper extremity DVT in the axillary or more proximal veins, low molecular weight heparin, then 2 Coumadin for 3 months, just treating it as you would a DVT in any other area. But a DVT in distal in the arm, again, is a low risk thing and probably should be assessed with serial ultrasounds. And then if a central venous catheter is involved with the DVT, if it's needed, the recommendation is to not remove the catheter, but to just treat the DVT. And so this then brings us to the reason why we treat DVTs, and that's to avoid the long-term sequelae. And so post-phlebitic or post-thrombotic syndrome is a problem that we see that sometimes is confused with venous insufficiency, but a lot of times can be from an old DVT that was either never that was never treated, or just simply has marked venous valvular insufficiency as a result of the DVT. So post-phlebitic syndrome is associated with pain, paresthesias, chronic lymphedema, pigmentation changes, venous stasis with varicosities, and venous ulceration. And that's kind of the grading of it as well. So here's examples that we've all seen of post-phlebitic syndrome. So you have post-thrombotic pigmentation. You have healed skin ulcers with post-thrombotic pigmentation, and then you have chronic leg swelling, skin hardening, kind of ruddy edema that people get. And then even worse, you get venous ulceration, which this can become infected and can have significant limitation to ambulation. And can cause just chronic problems, and extremely difficult to treat. We have very little to do for this. Compression stockings, wound care, not much can be done. Just a review of the novel anticoagulants. These are them listed. The updates to the guidelines have listed them as highly recommended for treatment of DVT. IVC filters are probably overused overall. But the only indication for an IVC filter is an absolute contraindication to anticoagulation and failure of anticoagulation in proximal DVTs, patients that are high risk for PE. People that have iliofemoral DVTs are much higher risk for a devastating PE. And if they can't take anticoagulation, IVC filter placement. So it's also considered in patients with hemodynamic or respiratory compromise, post-PE, when a second PE would be life-threatening. So that's another recommendation. Prophylaxis in high-risk situations with an IVC filter is also it's good to use retrievable IVC filters, and a permanent IVC filter is an indication for chronic anticoagulation. So avoiding permanent IVC filters is important. Catheter-directed thrombolysis. This is where you direct a thrombolytic treatment into the clot to try and decrease the clot burden and restore flow. We select patients based on their age, the location of the DVT, and the risk for long-term complications. And the goal is to preserve the venous function rather than ending up just dependent on venous collaterals or with severe dilation of the veins and avoiding post-phlebitic syndrome. Interestingly, when we treat a severe DVT, especially a severe proximal DVT, there is an underlying stenosis of the vein in greater than 50% of the patients, and that's treated with venoplasty and stenting. And that brings us to discussion of phlegmasia ceruleolens or phlegmasia albidolens, which is a limb-threatening condition caused by severe extensive DVT that has caused arterial compromise even to the leg and is a limb threat and is really a vascular emergency for treatment of DVTs. Iliofemoral DVTs are recommended for treatment interventionally with catheter-directed thrombolysis. And so if on your venous Doppler reports there's a report of a clot that's proximal to that saphenofemoral junction, we need to be called, and that patient needs to be treated. And we will see that patient at any time. Please don't just put them on anticoagulation and wait. Please call us, because this is something that can be an emergency. In a patient who, and again, the patient selection is important as well. In a patient with extensive metastatic cancer, extensive, a very, very old patient who may not be a thrombolytic candidate, then that may be something that we manage conservatively, but please involve us in that decision making. We like to see these patients and we want to be involved. And again, phlegmasia ceruleolens is when the limb is hyperemic, very, very congested with venous blood. Phlegmasia albidolens is when that limb is then hypoperfused and is white. And I'll show you an example of this in just a second. Inferior vena cava thrombosis can be associated then with pelvic and visceral venous congestion as well, abdominal pain, pelvic congestion. And ACCP guidelines recommend catheter-directed thrombolytic therapy only for selected patients with extensive acute proximal DVT. So that's directly from the recommendations. And so we're not just being cowboys treating DVTs, we're actually operating within the guidelines. Okay, life expectancy of greater than 1 year, low risk of bleeding. That leads us to a brief discussion of May-Thurner syndrome. This is where the right iliac artery overlies the left iliac vein, and you see here a diagram of the overlap, and that can compress the left iliac and cause recurrent DVT, and we see that especially in young people with acute unprovoked DVT. Provoked DVT is post-surgical, or if they've been on a long airplane ride, but this is just a spontaneous DVT in a young person. On the left side, we have to look for May-Thurner syndrome, and really the treatment for May-Thurner is stenting of the vein, especially in the context of a recurrent DVT. This is a patient of mine, and this is actually how his legs look. When I was looking at this, the gown's kind of pulled up on the right side, kind of accentuates the size of the leg. It's no perspective change. I didn't stand far over on the right side to make it. This is actually how he looked. The right leg was totally blown up. I was showing this to my 5-year-old last night. He wanted to see all these pictures, and he said, yeah, it's almost like a balloon, and it's almost like the blood can't get out of the leg. I'm so proud of you. It's so cool. So this is a 56-year-old guy who was traveling from Iowa to Arizona with his sister, and he had sudden acute leg swelling with ongoing pain, worsening swelling, and he was started on anticoagulation for a DVT, and was in the hospital. And he had worsening of his pain. And so he had an iliofemoral DVT with extension up into the IVC, and he was just being treated conservatively and medically. again, the wrong thing to do, because this guy is going to be, he's going to have incredible long-term sequelae of this. He's going to be incredibly sick. He's going to be dragging the leg around with lymphedema and with venous ulcers the rest of his life, unless something's done to alleviate it. There's no outflow. He's recruiting in tiny venous collaterals. That's why the legs don't pop. But he's totally dependent on collaterals at this point. He has a prior history of phlebitis of his foot, which I'm not sure what that was. It may have been another clotting episode below the knee, but no DVT history. Here's how, and I can't really make my angiograms look as good as Steve did, and I'm going to have to get some tutelage after this. But basically, this is how the initial angiogram looked. There was an extensive clot burden. What we do is we prone the patient, put them on their belly, access the popliteal vein, because again, leaving the clot below the knee is okay. Accessing the popliteal vein and then treating the clot from the popliteal vein all the way up into the IVC is very important. And so you see a ton of venous collaterals, which was very interesting. And I think I actually accessed a venous collateral. And this is where that prior history of phlebitis that he had in the lower leg was very interesting to me, because he just had this big plexus of venous collaterals, all of which were large, coming from below the knee. And they had extensive thrombus all the way up into the IVC. And you see here that this is actually the iliac vein barely flowing up into the IVC, and the IVC is up here. And this is the plexus of venous collaterals down across the knee, and then just extensive thrombus all the way up. And what we did is we laid down an infusion catheter, which is kind of like a drip line for your garden, and we just laid that down in the clot and infused thrombolytics throughout this clot overnight, and got some improvement in flow, as you see here. This is from the knee upward, and some improved flow, but still an area that was stenotic here up into the IVC, and this is kind of at the union with the IVC. What's very important with veins, because they're so compliant, is before stenting a vein, it's very important to image it, because the vein, especially when it's full of clot, you can underestimate the size of the vein, and so we use intravascular ultrasound to approximate the size of the vein and measure the size of the vein in order to oppose the stent as best possible. And so we did that, and then stented the vein right up at the union with the IVC. And he had torrential venous flow into the IVC after this. And I see him yearly now. The leg is normal size. He has absolutely no complications at this point. He can ambulate. He's got a tiny little bit of venous insufficiency. He wears compression stockings sometimes, but he's a totally normal guy, and the leg is the exact same size as the left leg. So this is an example of how we need to be seeing these patients and treating them aggressively to prevent that nasty, ulcerated, horrible complication of venous disease. And so just in summary, we need to have the correct paradigm for treatment of DVT. It's not just Lovenox to Coumadin to home. You need to think about the anatomical location of the DVT. You need to appraise the patient, their risk factors, if they're hypercoagulable, if they have an underlying cancer, they need aggressive treatment. Please consider interventional treatment for all younger patients, and really all younger patients. Please consult us on, because it's abnormal. Maybe they have May-Thurner syndrome, and that vein needs to be stented up higher, and they're just having recurrent DVTs down further in the leg. Or any patients with an iliofemoral DVT above that saphenofemoral junction, we need to be consulted on. Or any questions we need to be consulted on. Always think about how the long-term sequelae of not restoring venous flow will influence that patient's life. And then trend towards non-inpatient management with novel anticoagulants means that we have to have the accurate diagnosis and accurate treatment. So a lot of these patients are being started on Xarelto and being sent home, and we never capture them. So please be thinking about that as you see these patients. Thank you very much for your attention. Thank you for the opportunity of being here. I'll take any questions.